Welcome everyone to today's webinar. I am Becky Verzak with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We're looking forward to hearing your questions. At this time, it is now my pleasure to turn the floor over to Rachel Sparks to begin today's webinar.
Hi, and thank you, Becky. And thank you, audience, for joining today's webinar, Building a Culture of Patient Safety in Today's Healthcare Environment. I'm Rachel Sparks with Xenex, and today I'm joined by two accomplished hospital executives to explore that topic. Paul Hiltz is recently retired from his role as the Network Chief Executive Officer of Community Mercy Health Partners System after a career spanning 30-plus years of executive leadership throughout the system. He still chairs the Operations Advisory Council and sits on the Health Advocacy Committee at CMHP. He was the founding president of Mercy Health Select, which was one of the first accountable care organizations in the country, and named one of the top 100 ACOs to know by Becker's Hospital Review. We're also honored to have Kelly Curry, formerly the Executive Vice President and Chief Financial Officer for Health Management Associates, a leading independent health research and consulting firm, where he also served as the Chief Administrative Officer and the Chief Operating Officer. Kelly is an ordained minister and currently serves as the Chairman and President of Foundation and Christ Ministries. It's a multifaceted, cross-denominational family of ministries that he and his wife founded in Galway, Ireland. It's a really dynamic foundation. It provides education and outreach to youths, including work programs and counseling. But needless to say, both of our panelists have spent their careers guiding large healthcare organizations to success and profitability. So we felt they were perfect for guiding us through this topic. Today, we'd like to see from you, Paul and Kelly, how you think we got to here, what here looks like, and including how we want to measure patient safety, how we calculate the benefits of patient safety initiatives, and what tools can make a significant impact. At our close, we'll also talk about the future of patient safety and healthcare. And this webinar for the audience will be a question and answer format, a little bit different than some, but at the end, if you'd like to see the slides, we will be making those available. So to go ahead and get started, let's talk about the culture of patient safety. Paul and Kelly, you've both been in positions that give you an orchestra view, if you will, of healthcare and patient safety's evolution. So I'd like you to tell us how you feel a culture of patient safety is defined and how did it come to be? And Kelly, I know that you are a history buff, so why don't you start?
Well, thank you, Rachel, and thank you very much for having us. And Paul, it's a pleasure to work with you. And thanks to each of you that are out there that are joining with us today. And we appreciate your interest in this topic, and we look forward to learning what you are interested in and what questions that you have to help broaden our knowledge as well. But I guess, probably most of us would be familiar that in patient harm medical errors that they account for about 10% of all U.S. deaths, according to the latest data. The statistics show that in the U.S., 1 in 25 patients will contract some sort of infection while they're in care, with as many as 75,000 of those passing away, which is a terrible thing. And there's also a great cost associated with it. And, I'm having been around healthcare the number of years that I have, originally the kind of thinking before you had to err as human coming out, that infections were just sort of a fact of life, a thing that occurred in hospitals. And they didn't really, it was kind of after the advent of To Err as Human that the idea that there was more that needed to be done to prevent these errors, and or treating them as errors to prevent them. And also bugs continue to get more serious and more difficult to deal with, and tougher to treat with a antibiotic. So on the timeline there, you can see what we put together that kind of gives you an idea of the way we think the history has developed. And really many of you out there probably are well aware of the Josie King story, which was a terrible event, but it was probably one of those things that really galvanized attention and helped people to really face a conviction and to get, I mean, we had committees before, not to say that it wasn't an important issue, that we didn't look at these things, but I think it heightened the awareness and the attention that needed to be given, because hospitals are complex places. There's a lot going on. There's a lot going on with each individual patient's care, and there needs to be a lot of eyes and a lot of participation in the process of guarding patient safety. And I don't know, Paul, you might want to comment at this stage.
I think again, thank you to the audience for participating in this conversation. One of the interesting things when we look back the last 15, 20 years to the Institute of Medicine, you think how far we've come in many ways, but still how much further we have to go. Going back to when the Institute of Medicine first started talking about patient safety to err as human, it seems that we spent a fair amount of time debating the data and almost and doubting and trying to justify that, hey, this can't be this bad. But we've certainly moved past that into an era now where it seems that finally the quality directors aren't so alone, and the culture is expanding, starting at board levels in many of the systems and being driven by physician leadership and executive leadership. But I think we've come a long way in terms of getting the stories out. And again, the Josie King story is still so powerful. If you haven't looked at the Josie King Foundation website, it'd be there's some great videos and great tools there. But it certainly is a conversation that is much more widespread than it was 10 years ago as these cultures are developing around safety.
You know, Paul, that's a really, really, really good point. Sorry, Rachel. The idea, you know, in the past when we had quality committees and infection review, et cetera, up until really the 2001 post period, it was the sort of thing those committees met over lunch for 15 minutes, and there was a one-page report maybe that came up from that to the place where we are now, which is where it should be, and getting the attention that it should be, that at a board level you have patient safety committees that are functioning as an element of that board, and that's a tremendous improvement.
Thank you both. The points you're both making about how much more data we're really looking at is fascinating, and it kind of leads us into our next question, which was, you know, we are really trying to incorporate a lot more data analysis and metric watching, and scorecards are a useful tool that we know that a lot of executives use. But Paul, I was hoping you could speak to how scorecards could be used throughout the entire spectrum of patient care to enhance patient safety. And then Kelly, I'd love to hear also how you can speak to, you know, scorecards in the context of hospital revenue as a CFO.
That's a great topic. The scorecards, and you know, I don't think there's any one perfect scorecard. We have a couple of examples here, and there are many of our attendees today that have great scorecards of their own. But it's interesting when you think about going around the country and speaking with community hospital boards. All boards will tell you we deliver high quality care in our organization. They truly believe that, and I think that the issue is to make sure we're capturing the objective data to make sure, how do we know we're delivering high quality care? And at each market and different points of time, there will be more important metrics, you know, market by market for the quality. So I think it's just great to get alignment around the scorecard. And like I said, there's many great examples out there, but really starting at the board level and going through physician leadership and executive leadership to get alignment on what are the scorecards telling us, and how do we move those metrics? How do we move the needle to an excellent level?
You know, Paul, This is one of the things that we did as an institution. We did a study, commissioned a study to be done where we contacted I think it was a population of about 1,000 on a statistically valid basis to ask them what they utilized to select hospitals. And this was done about 5 years ago. But one of the things that we found out at that time, that one of the number one criteria that people used in selecting a hospital was the amenities that were offered. In other words, can I get a lobster with my dinner, sort of thing. And and while I understand that, I don't. I mean, for one thing, I think it's important, especially in today's environment with deductibles being what they are. If people were going to go spend that kind of money on themselves individually, they would certainly expect the highest in professional services. Should they be attending a hotel, a nice hotel in a luxury location, for the amount of money that they're spending to be in a hospital personally? So I can understand the connection there that it's a huge expenditure but I think that there is a shift. I know that more and more people that I talk to in my age range, and I'm older than probably most participating, but are starting to go to Medicare.gov. They're starting to look at quality ratings. They're starting to, I know every once in a while over a cup of coffee, and perhaps it's because of my background, people will ask me about what would I consider in looking at in selecting a hospital. And it's now that I'm a granddad, which is an awesome position that I enjoy. My daughter's been in the hospital a couple of times having those children, and I've noticed on the floors that they have their dashboards posted, and I always pay great attention to it and read them pretty close. And I've had a couple of nursing personnel, and there were busy days that when they had a second, that would come by and ask me what I thought, or ask me about the scorecards, and it's interesting from those conversations. It appears that people are starting to pay more attention to that, and becoming a bigger factor in selecting where you go for healthcare, especially in light of the amount of money it's going to cost you personally to seek your healthcare, and also in looking at people looking at choosing their physicians. I don't know if that's been your recent experience or not, if that's just an anomaly for me.
No, I think you're right, and I think too, and the one that's on the screen right now is a good example of, and the patients, but frontline staff too are very much more interested in these than they were even 5 years ago. When you put up metrics around mortality and CLABSIs and CAUTIs, now more of the frontline staff are getting interested in, okay, what is that? And more importantly, what can I do to impact and improve those metrics in whatever role I'm in, whether I'm in environmental services, nursing, you name it. And I really think that is a key to, as we talk about developing an entire culture around patient safety and quality.
And, it's a team thing, that's for sure. It's got to start, it's not something that it's the job of the folks on the nursing station. I mean, they're certainly a key element, but if it doesn't start in the C-suite office, then it's not going to transcend the organization, because each and every person that's going to be engaged in the hospital environment, they need to be engaged in taking the responsible actions for patient safety and care wherever they are, in whatever position they hold, whether that's in the business office or any other area of the facility.
So when we do explore this ground level awareness, one of the things that we wanted to talk about today was what is really the dollars and cents of hospital-acquired conditions, HACs. So, we all discuss hospital-acquired conditions and their influence on Centers for Medicare reimbursements, but those are really large numbers and sometimes kind of hard for everyone to grasp. How do HACs impact a hospital financially on a per patient level at the floor? And Kelly, as a CFO, I'd really like you to lead off and tell us how you view that when you think about how that all adds up.
Well, Rachel, anytime, hospital margins, and particularly, since commensurate with the introduction of Obamacare, hospital margins have been under considerable pressure. They were before that, but there's a lot of emphasis, both privately and in industry as well as in government, about hospital costs and the rising expense of healthcare. So it's a factor that concerns us all as Americans. And anytime that you're being paid less money in a constrained environment, it's going to impact your operations and the flexibility of decisions that you have. A smaller, typical $150 million net revenue hospital, which is 150 beds or so type facility, if they're under a hack penalty, then they're losing $1.5 million in reimbursement for 50% of their patient base, which is about what their Medicare business would be. And on a look at that on an average basis, that's as many as 20 jobs. It's also $1.5 million that you don't have to invest in technology. And just like mobile phones and tablets and the pace of electronics. If you buy the latest and greatest TV that's whatever pixels it's got, the day you take it out of the store, they're introducing another one that's got 2 or 3 times that capacity, and yours is worth half of what it was, if that. And in the same way, not quite at the same pace, but at the same way in a hospital, technology moves so quickly, your ability to invest and maintain a competitive edge in your healthcare delivery system by continuing to invest in the technology that's needed to be current. So and then with the individual costs associated, bringing it down to the patient level and the cost there, some of the things you look at that are going to happen. First off, you have an increased drug cost because they're in the hospital, and not only are you having to, and speaking here of a typical Medicare patient, I think statistics would show that you require probably 90% of your health care in the first years and last years of your life. So we're probably talking more generally about a Medicare type patient. But Medicare type patients are older, and so they typically have other comorbidities and things that are being treated for. So they have maintenance medications that they're receiving while they're in the hospital. So if they're staying longer, there's a higher cost associated with supplying those medications, which of course this is a flat fee, essentially payment environment. And then you have the cost of the medications that are going to be needed to treat the infection, which ordinarily, if you have comorbidities, you're going to be more at risk to whatever those infections are, and which means that the cost of treating those infections and someone that may have and if you're in the hospital, your immunity system is probably compromised to some extent because of the treatment that you've been receiving. So the likelihood of having to use the more recently developed, which of course carry a higher cost. Then there's the demand on your staff. They've got you've got more invested in taking care of patients that under different circumstances would not be in the facility at this stage. So you're looking at +3, +6 days. In fact, I think there's data that's on your screen right now that kind of shows the sort of impact on length of stays. And another factor that's often not talked about, at least it's in my experience, Paul's, yours may be different, but with this, but having one of your on-staff RNs out because they're sick, one of your normal caregivers, is hugely expensive. For one thing, it's just by nature of the kind of constitutions that healthcare workers develop by working in a hospital environment. They have strong resistance. So when they get sick, they usually get really, really sick, and they're out for a number of days. You lose the advantage of having an experienced person that's a part of your team, probably being replaced with someone who is a part of a temp staffing organization. They're not going to be as efficient. They're not going to know the routine. They're not going to have the same experience level at that location in that hospital. They may be a very experienced person, which is great, but nevertheless, there's something lost to the learning curve of not having worked there. So there's a productivity cost that goes along with that, and then there's the fact that they're not part of your normal team, and consequently, they don't have the same potentially the same cultural knowledge of the institution. So all of that carries along too. So the net impact on the of an additional stay in the hospital, not to mention the patient having to undergo the treatment, additional treatment that they weren't planning on, and their the impact on them as an individual and their families. There's just a multitude of costs that accumulate. We had done some studies that if we had just a typical average Medicare patient, that our costs would average, this is data 5 or 6 years old, would be a minimum of about $30,000 just in direct costs, not including the indirect costs that I was in reference to. If you have an infection problem, your staff being out, et cetera. Paul, you might have some comments.
Well, I really like the slide you put together here, Kelly, and I was going to just recommend, I know we have a large number of quality directors and infection prevention specialists. As a CEO, I always have appreciated when somebody was advocating for whether it was an equipment or supplies or programs to reduce hospital-acquired infections. I think this can be a powerful tool to advocate for whatever is needed, because these are real dollars here. And I think showing that there is a return on the investment to reduce, I mean, to find, $20,000 and bring it to the bottom line is hard to do. But if you just, eliminate one surgical site infection, that's $20,000. So Kelly, I don't know whether you would have any advice for our participants today, but I would think that in their organizations, if they worked with a financial analyst or somebody in the financial team, they could truly put together a return on investment for whatever initiatives they want to embark on to reduce hospital-acquired infections, couldn't they?
Yes, sir. I think, well, when you think about it from the perspective, particularly you with your CEO background, if you want to develop a new service, first off, you're talking about net revenue dollars that you could generate based on payer type. So whatever you can charge for that service, you're discounted to a net revenue figure that you can receive for it. And then of course there's the cost of delivering that new service, which is going to go against the net revenue. So, anything you implement, you would hope that you can derive 5% to operating profit from the advent of that new service. Whereas if you eliminate an infection, that's an immediate $20,000 or $30,000 that's going to your bottom line, which is available for allocation for other things in the facility. It's one of the sisters that I spoke to one time, her expression was, I don't know if it was original with her, but I always liked it. She said that there's no money, there's no mission. And the idea that you can develop a savings, and the benefits are really I'd call them exponential, because if you take actions that reduce you reduce infections by, say, 10 and a quarter, okay, then that's a significant savings to the institution. I mean, that's as much as 800,000 real dollars in a year that can be brought back to the institution. If they are also under a penalty, then it's going to bring back that 1% that they've been penalized as well from that by improving the performance scores for reporting. So it's going to have a lot of knock-on benefits, as well as improving more importantly, and we're in the business of healthcare, and what we want to do is we want to take care of patients, and we want them to have the best experience they possibly can have, both themselves and their families. And we all know that not everything that, unfortunately, that happens in a hospital is positive, because some illnesses are such that there's the best we can do is we can ease the suffering, and we can do some things palliatively that benefit the patient. But whatever it is that we can do, we want to do with excellence, and we want to do in the best possible environment to return the best possible experience for all involved. Because the whole reason, I mean, I'm sure your experience is the same, but everybody I ever met working in a hospital, regardless of what their duties were, what role they played in the facility, they were there because they had an opportunity to help people, and they found that to be a rewarding position to be employed in. And so whatever actions that we can take, and whatever benefits and technology we can bring to improve the environment, the patient care environment, those are going to have knock-on benefits. And interestingly, most of the things that you have to do relative to creating a controlled environment for infections management is they're not hugely expensive. In fact, they're really more in line with routine costs. And of course, which is great, because almost hospitals are almost everything in a hospital costs a lot.
Well, to our audience, I would add on this one last thing on this slide. Don't underestimate the impact that a slide like this can have on a culture of employees too. I think getting more and more people to understand the economics of hospital-acquired conditions, it does help, again, raise the culture around safety.
Yeah, that's
agree with that.
Excellent point. Well, as we are talking about this particular topic, C. diff, currently C. diff, MRSA, and surgical site infections account for 45% of the total HAC calculation, and then another 30% is comprised of CLABSI and CAUTI rates. So with such a large portion of the HAC score dependent on infections, as we're talking about tools and talking about justifying those tools, which tools do you find powerful for impacting those infection rates? And Paul, as a CEO, I'm sure you've seen many different tools. So why don't you speak to this first?
Well, I think in terms of reducing infections and the whole notion of bringing sort of evidence-based management to the process is something that I've been advocating for. Antibiotic stewardship is we certainly give the doctors a ton of interest around that, and a lot of oversight and so forth. But the simple things, the hand hygiene, things around EVS, all the other things probably haven't been given quite as much attention as we could. And it's, as I've said, there's no real one single silver bullet that can solve the issue, but it's 1,000 little bullets that all of us have to get interested in. And again, looking at what the evidence is that can impact it. And just as we talked before, it's not just the quality directors, and it's not just EVS or housekeeping that can keep infection rates down, but there's many factors that we need to put into play to make it a safer hospital, safer organization.
one of the things that, I know that we had many programs encouraging hand hygiene in the facility, hanging hand units, hand washing units about every 10 feet to encourage it. But one of the things that that doesn't protect against all forms of infection. I mean, C. diff isn't impacted by that, for one, and there may be others that I'm not aware of. But that was one of the things that it's not. While you can have a great hand hygiene effort, and you can encourage that, your point that it's a team and there's multiple steps that you need to take is well advised, because I learned early on working in a hospital. I became a fanatic about washing long before the hand hygiene thing was I guess, which has been around probably for the last 15 years, really is being pushed. But before that, I was washing my hands all the time, because I noticed working in a hospital that a lot of people got sick there.
So which tools, in terms of improving the environment, do you guys find most impactful? We've talked about stewardship, we've talked about hand hygiene, and you're right that we do need to scrub with soap and water to kill those C. diff spores and get them off of our hands. So which tools do you feel are most useful in the patient healthcare environment?
I don't know, Paul. You guys might have looked at different ones. We looked at a number of different things, and of course, one of the your frontline tool, your number one tool is your EVS, and having a set program for training folks on how to go about cleaning the room, and ultimately, I think I think a lot of hospitals, organizations, either standalone or hospital organizations, have probably moved. Many of them have moved to outside companies to provide those services as a means of, as a cost management tool, by virtue of just some of the differences in the way the responsibilities of managing that area, and in terms of running that as a business, because in and of itself, it's quite an area that requires good attention. And I know that most of the time, like, for instance, when I started out as a hospital CFO years ago in small hospitals, EVS reported to me, and it's like, what did I know about EVS? I mean, I had to get an education on it, but it was, I could tell you that there was nothing that I studied in accounting that prepared me for that responsibility. But studies are showing that, and I think they're out there and available that publicly, that on an average basis, you got about 50% of the surfaces are not clean. What's happened is that really the bug has been moved around on the surface or pushed into a corner or something like that, and that's not. I don't think that's a function as much of a lack of attention or poor performance. I don't really think so. I think it's just a function of the fact that when you have a lot to do and you're doing many, and as you go through that process, that as a means of controlling it, it's probably always been about that. In our experience, it just is that as the bugs got tougher over the years, that this became more and more apparent than perhaps what it was in the past. Have any thoughts on that, Paul?
Well, and I had the great privilege of working as an environmental services worker within this last year, and spent a day doing room cleaning. So I got a great look at how difficult a job that is. And so for the people on the call today, they're in that work, God bless you, that is hard work. And because of the way things work in a hospital, the discharges tend to come in all at once. And so the people trying to turn those rooms over under great pressure to get the rooms cleaned, And that really is sort of what got me interested in looking at, well, what are the other tools? And the multi-spectrum UV light, I mean, if you look at the data on that, it's pretty compelling to look at what that can do to an already clean room, and the benefits are kind of amazing to me. And just looking at everything we can do to reduce C. diff and MRSA and these other things, with little time. I mean, very little time really taken to do it. So I think it's a key part of the arsenal that we've got to bring to the bugs.
Did you in your experience, did you ever work with HPV? Did you use HPV at all?
No.
Yeah, we've looked at it, and I have lived in Europe for a number of years, and they use it there. It's a little more typical to see it there than it is over here, but it is effective. It is an effective means, but it is a lot more. To your point, it's a lot more intensive in terms of labor to set it up to do it because of what's required to prepare the room, and then the length of time that you need to allow it to operate to complete the process, which takes the room really out of service, which, as you were noting, and it is that way. It's the way it always is. Discharges always come at the same time, and then there's a demand because of what's been going on in the ER all morning, that demand for beds, and so it has some definite shortcomings, and then there's an ongoing cost, of course, and then looking at UV. You have experience using multi-spectrum, right?
Yes, yeah, and the results were pretty dramatic in terms of pre and post using that technology.
Yeah, probably the most interesting thing that I noted in looking at it as an alternative was the fact that single spectrum's focus being really limited in terms of the range of infections that you're going to be dealing with in a hospital setting, and so I really found it pretty compelling. Not to mention the clinical studies that are available showing the effectiveness of multi-spectrum, but I was pretty impressed by it. And your point is on the time. Yeah, it's as opposed to something like HPV, which is, you're talking in terms of hours, you're talking about probably an additional 8 minutes or so. Was that your experience, additional 8 minutes per room?
Yeah, that's the big, I think, for me, the time thing was a big thing, because every minute is counting, and the staffing is so tough that the quicker we can get those. And again, going back to the culture, I think when people see that we're looking at what does the data say is the most effective way to keep the place safe and clean, and that again helps spread the culture of safety.
Well, the studies show that kind of result just almost across the board without exception. The experience has been very, very compelling. I do know that when my daughter was having babies, one of the questions that I asked when I was looking at the scorecards, I was asking the nurses, I said, do you guys use UV infection control services? And when my first grandson was born, the nurses said, yeah, we're just starting to get it. And I said, what do you think? They said, well, they didn't really know. And then a couple of years later, when we were back in the same place for my second grandson to be born, I asked I can't say it was the same nurses, but I asked the nurses what they thought, and they were all big fans of it, and they felt like it had made a significant impact in creating a safer environment. So and it's, to me, that's like hearing it from the horse's mouth, because those are the people that are dealing with the impact on a day-to-day basis of the fallout of environmental control efforts that are not functioning at maximum efficiency. So that was great to hear, and as a grandpa, greatly comforting.
Well, one thing that occurs to me as I hear you both talk about this is that it seems like the application of, I guess, what we would call evidence-based medicine to these environmental conditions in the hospital is becoming kind of a trend. Am I wrong there? Is that something that you all observe as well?
I think you're right, and I think that there's a sort of an increased level of interest from the general public on those types of topics right now too. Trying to find the people in the business community, especially, I noticed over these last couple of years, have been asking what are some of the latest technologies, what is the evidence saying around reducing infections, and it sort of waxes and wanes. There will be an article in the paper about a real bad bug, and then the interest goes up. But I think the trend is more people are getting more and more interested in this, because if they're going to have an elective procedure, they do their homework.
Mm-hmm.
Well, you can see, there's a lot of indicators, if not the patient themselves, and certainly the payers, because there's a lot of indications. For instance, there's what's being done on an outpatient basis today versus what was being done, even 5 years ago, is amazing. And it's been a nearly 20-year journey now, and as time goes by, more and more people are going to be they're going to be more aware, they're more educated about hospital care, and also because of the movement to have more patient involvement in the process of selecting healthcare is going to make them more aware, and they're paying more individually, so they're going to be more engaged in making those choices. And so I don't think there's much doubt about it that there's going to be a higher and higher degree of awareness, and that's one of the questions people will ask when they're being told they're going to need facility care. Well, what's your infection rate, and what's your experience? Are you under penalty, or are you not? And ultimately, there'll probably be some kind of grading system that will be available. But the emphasis on by insurance companies as well as the government to not pay for to outcome-based reimbursement and not pay when there's adverse conditions present. That's not going to go away, regardless of whether or not Obamacare is ultimately changed into something else or not. That's here to stay, I think. And then I've read that they're looking at vaccinations for C. diff. Well, vaccination's always going to be cheaper than trying to treat the condition, so there's going to be more emphasis there as well. I do imagine that bugs will continue to gain resistance in the facility, so there's always going to be an emphasis and an importance associated with maintaining an effective environmental control safety environment for infections.
Well, that's actually where we were going next. What is the future of patient safety? What's on the horizon? So, we've talked a little bit with you, Kelly, about that. Paul, do you have any thoughts there as well?
Well, I think the future and the present right now is something that's on my mind. I think with all the uncertainty around healthcare reform or repeal or whatever, one of the things that I think is important for us as healthcare leaders as we're working with our teams is to keep a focus around patient safety, regardless of what policy comes out. I think trying to keep our teams engaged around taking safe care of patients is really important. So I hope we can keep that in the future is certainly going to be just, I think, increased transparency or transparency on steroids. There will be more and more public scorecards, and I think that's a good thing for all of us. I guess I would suggest or recommend to our attendees today 2 websites to kind of keep track of from time to time. One would be the IHI, Institute for Healthcare Improvement website. They've got a great website with different futuristic prognostications, I guess. And then the Commonwealth Fund is another one I would recommend people take a look at. It's a lot about health policy as it relates to patient safety and quality. And I think those are 2 great places to keep informed about what might be the future.
Yeah, I think that's a really good suggestion, Paul. The being able to stay abreast of where the the industry and where the payer environment is moving is going to continue to emphasize the need to be on the forefront and keep an emphasis on maintaining a high degree of vigilance.
So for our audience, that's ihi.org and the Commonwealth Fund at thecommonwealthfund.org. I feel like we've got about 12 minutes left. Why don't we jump into a couple of questions that we have from the audience? And let me just hop over here. So Joanne has asked, is it important to identify what the scores on the dashboard mean so that staff can speak to what is improvement or not, and why has it improved or not?
Great question. So yeah, we probably should have emphasized that, but really making sure there is a clear and consistent understanding of the metric is really, really important. And then connecting those dots for frontline staff to say, well, the initiatives we undertook to reduce hospital-acquired infections were A, B, and C, and we believe that A and B had a very strong impact on reducing these. And I think that's a great question, because the staff want to know that their efforts have an impact and that they're making a difference.
Wouldn't you normally have, as these were coming out, wouldn't you think, Paul, that normally you would have updates with the staff regarding the results that have been obtained?
Yes, I think that's a great win. And as we construct scorecards too at the front end or at the beginning of the measurement period, to be able to say, here's how we're going to measure this, and this is what it means, so that we have that alignment and the input into the scorecard too, quite honestly.
Right. Good point.
This is kind of an interesting question. I'm going to go ahead and read this one. As a manufacturer of products, this is Brian asking, that support these efforts, I assume he means for patient safety, we've had difficulty getting hospitals to be open to new ideas. And do you have any suggestions how or whom we should be contacting?
Well, I would refer back to Kelly's slide that had the cost of not doing anything, because it's expensive. And I think that's one of the best ones. And I also think that engaging the community and the board / the community and getting them excited about improvements in patient safety is an important step too. Many times the foundations around community hospitals would want to take on a patient safety project and help fund some of that. So I wouldn't discount the foundations in this equation too.
I think just as a reference point too is that the pace of change in as Obamacare has been implemented, the pace of change, and Paul, gosh, I guess with your recent experience, you could tell me whether I'm on the right track here, but I'm sure that many hospital managements feel like they're drinking from a fire hose just to try to stay even with what's going on. And one more thing, particularly when you're talking about cost measures, ordinarily don't gather as much interest as opposed to revenue generating measures. So that might be one reason why there has been, I wouldn't call it a lack of interest. I think it would probably be a more a function of time. And one thing's for sure, that as these costs mount and as as you begin to budget in, I mean, every year hospitals do budgets, and when they're budgeting in a penalty, that's real money that's coming out, and they're feeling it. So it's not. There certainly is an awareness that there's a cost there, and I think probably continual seeking and knocking while they have as they get more and more adapted to the change in the system that they're dealing with, you'll get more attention.
So a good question we have here from Susan. Do you see the use of patient safety organizations, or PSOs, to further the coordinated efforts of patient safety initiatives? So I think she's asking, do you see those to be valuable initiatives?
I think so. Again, it's going to be, I don't think there's going to be one thing that's going to be the answer, but I think that anything to increase the awareness, the understanding, and again, to help drive that culture is going to be helpful.
Okay.
And I think there's a much greater appreciation for this. I mean, even in the last, I think probably in the last 9-10 years, there's been a much greater. I mean, I don't know, Paul. I mean, 10 years ago, did your board have a patient safety committee?
No, I think you're right. There's a lot more at that level. There's a lot more interest in patient safety than there was 10 years ago.
Yeah, I don't think when I would interact with either our board or with the boards of other institutions, I don't think we were, 10 years ago, I don't think we were ever asked a question about specifics regarding patient safety programs, but that changed. They began to be asked because the boards had patient safety advocates, as a part of a committee. They were that were interested in it, and so more questions were directed that way. So it's a positive. And there's, I mean, after all, which of us? There's not one of us, because anybody could be anybody's sister, cousin, aunt, uncle, or brother that's in the hospital, and what kind of care would you want them to receive? So it's something that we can all agree on.
I have a really, I think, a fascinating question here from Jared. Why is there still a perception of soft versus hard costs when dollars are dollars, both of which are real?
Well,
I think that was directed towards you, Kelly.
And I appreciate that. I appreciate the reason for the question. And there is an overwhelming logic to your observation, Jared. But there is a difference in terms of how they're evaluated. Soft costs are something that are not necessarily ongoing, whereas hard costs are. So it's a function between fixed and variable. But what has happened and what is happening because of the issues associated with operating a hospital in a modern environment is there's a greater and greater percentage of costs that are fixed or hard, and which is how I would interpret your question. And because of that, there's less variability in what you can do in response to changes in volume metrics, and those are big issues now because of the continued shift to outpatient away from inpatient. I mean, I was just speaking the other day with a physician friend, and he was talking about the fact that doing essentially outpatient for knee surgery, knee replacement surgery is being done. It's kind of in the early stages, but that's likely to become a lot more frequent option, especially for younger patients that don't have the comorbidities as an alternative. So, that's a as you think about that resource-wise in the hospital, and recognizing that I'm not, I don't think a lot of people realize this, but really in a hospital, it's oncology, orthopedics, and cardiology that produce a return for the hospital to reinvest in its future. And so as it changes in that environment, and we've seen big changes in cardiology because of the improvement of medications, and which is a good thing, but nevertheless, it's impacting the hospital environment, the inpatient care environment, which creates a greater shift to outpatient. It affects that relationship between fixed and variable cost, and creates a lot of management challenges. So in that regard, that's why I hope that answer, it was a long answer to a short question, but I hope that's helpful.
I'm sure it is. I also have a question from Sherry that I think is very interesting. Have either of you instituted an individual physician scorecard for antibiotic stewardship?
We have had individual scorecards for, and I don't know that it's a perfect one, but it's there are some out there.
Okay.
That would not be an area that I would have been involved in, so I could not respond to that.
Sure. And I also had a question from one viewer who was asking, about the daily dashboards. Where were those? How were those done? In our research, I know that to be able to provide an example, we sourced healthcatalyst.com, and again, these slides will be sent out later. So that's certainly one vendor that is offering assistance with that. And we don't have a whole lot more time left. I think that we have. I think that we've touched on pretty much all of the questions. There's one final one. I'm not sure if you guys could address possibly, but we'll give it a shot. From Susan, are there high quality patient safety initiatives related to the opioid epidemic? Excuse me.
Well, I'm aware of one that we were beginning to initiate last year, which was to go opioid free in the emergency department. So really looking at the usage of those kind of drugs and starting with the medical staff to get real clear about when those would be used and for what conditions, and trying to limit the conditions under which those would be used in the emergency department.
Okay.
You really need more development in a non-opioid pain control medication. Aspirin still, I guess aspirin is really, still one of the best, but it was certainly seen that some form of non-opioid medication is much needed.
Mm-hmm. Well, I think we have one that I'd like to end on. One last question from Eric. Do you think there's a lack of patient awareness of this issue, and do you think that raising awareness would increase patient safety, or is it primarily a provider issue? So, I think that's asking, do we want to work harder on educating patients to ask those questions about scorecards, about their own hospitals' rankings, or do we want to put more emphasis with the providers and ranking them and teaching them how to respond to those rankings and improve their behaviors or their rates?
Well, I think that the patient engagement's really, the data is showing, especially in the ACO world, that if you have engaged patients, they tend to do better than the disengaged patients. So I think it's my focus would be on engaging the patient.
Well, I think it's gonna transpire anyway. But I think there's a certain level of trust that exists out there between patients and their care providers that they're doing the best thing for them, And while I think that's wonderful and that's a good thing, that as a profession that's the reputation that it has. At the same time, I think as professionals, engaging our patients to be aware of differences that might exist over issues like this is also a responsibility.
Great. Well, thank you. And thank you both so much for joining us for this insightful discussion. We've hit our closure time, and we really, really appreciate your expertise and your knowledge and sharing it with us. Thank you to our audience and to Becker's again for hosting us. And I'll let Becky wrap that up.
Wonderful. Thank you so much. Thank you to our audience for attending today. And again, thank you to Paul, Kelly, and Rachel for leading today's discussion. I hope you all have a great rest of your day and join us for future webinars. Thank you.